Our next speaker is Professor INDUMATHY Santhanam. She's a senior professor of pediatrics and a specialist in the resuscitation and emergency care in children. She currently works at the Simulation Lab for Pediatric Resuscitation and Emergency Care at the Institute of Child Health, MMC, in Madras Medical College in Chennai. She is a WHO consultant now and a project coordinator at the Regional Collaboration Center. Her work focuses on the development of protocols for resuscitation and emergency care in children and in the training of healthcare personnel in these procedures. She's the author of several textbooks of undergraduate and postgraduate pediatrics and in pediatric emergency care. Her passion and special interest is in the training of healthcare workers and the complex procedures in resuscitation and pediatrics, especially in the context of healthcare workers who are less skilled and in semi-urban or rural areas. Her topic for today is on the workflow and decision process in pediatric emergency care. Dr. Indu?
Thank you. Thanks, Sundar, for that nice introduction. So my topic for today is workflow and decision-making process in pediatric emergency care. A little bit of the background of how we developed this process. I used to work in a large volume children's hospital with very limited resources. We had no advanced intensive care facilities, mechanical ventilation, or investigations that is associated with critical care. And we also lacked experts, round-the-clock expertise in critical care, because our first main workforce are resident doctors who have virtually no experience or expertise or training in emergency care, especially pediatric emergency care. So I had to evolve, because we are a large volume center. We get the worst cases and the poorest of the poor who reach us very, very seriously ill. And these doctors had to be given a very simple, basic process where they repeatedly do this till the child gets better. So, so the problems we faced was various: sepsis, today COVID, earlier it was dengue, it was SARS, etc. Asthma, bad seizures. Here you can see burns, trauma, poisoning. And that's the kind of children we receive in our department. And so our mission was, how do we achieve neurologically intact survival? How do we young resident doctors take the right decision when these children reach them 24/7, 365 days? So here you can see a child who's brought unresponsive. He's not breathing. His heart was not functioning. It had to be activated. He's being provided breath, and the cardiac medications are on flow. How do these resuscitation decisions, how is it that the brain cannot survive without oxygen for more than 5 minutes? And already those 5 minutes have gone. We need to do everything fast. The decisions have to be really fast. Our actions have to be really fast. Our assessment is fast, and it has to be documented rapidly. But how do we do it? So that's the process that was innovated at the Institute of Child Health Emergency Department. And over a period of time, we found that mortality in this low resource setting was on par with any Western center with a huge amount of infrastructure. We were able to provide the same kind of care. Here you can see envenomation, you can see the severe sepsis, the asthma. The mortality rates were comparable with the best, despite the lack of technology. So it was more based on the clinical process and the fact that it had to be done meticulously. So how did we do this? It was a systematic process, and these protocols were customized for our Indian children. American protocols did not work for us. Western European or Australian protocols did not work for us. Our children could not tolerate. Many of their recommendations were caused the child to worsen. So we had to find or modify our protocols for our population. And this was based, as I mentioned, the speed is a very important component. We call this a 1 minute model, and it involves several members of a team. It's an orchestra. Each member has to do their job within a minute and then reassess the child to see how best this child has improved or deteriorated and take the next decision and do that within a minute. We called it PRAME. PRAME meaning love in all Indian languages. It's an acronym which was used to describe pediatric resuscitation and emergency medicine. Subsequently, this became an initiative where when the government saw the impact on children's hospital mortality, it has now been implemented in the state of Tamil Nadu under this PRAME initiative. It has been established in all the rural district hospitals as well as medical colleges. But before that, let's see what the process is. This PRAME process is about 4 steps. It has this 1 minute rapid cardiopulmonary cerebral assessment. For the non-medical people who are listening, rapid is a rapid, it's quick. It's cardio, heart, pulmonary, lung, cerebral, the central nervous system, assessment. The entire comprehensive assessment is made within 60 seconds. This is rapidly documented in a pre-formatted case record where you simply circle or score out. And then using a simple card, because vital signs vary with age. A neonate may have a heart rate which is normally about 140 per minute, but an adult has a heart rate of 60 to 70. So these heart rates or respiratory rates, the blood pressure varies with age. And this has to be interpreted in terms of the age of the child. So doctors, you cannot hold it in your brain. So we use a small card to interpret vital signs. Then we derive what is known as a physiological status. To give a simple example, a child may come with fever. He is dengue positive. As per investigations, he's having dengue. But this child just has fever. He's otherwise playing. He's taking his feeds. He's normal. He comes with this fever to the OPD because the mother has found that he is dengue positive. Another child with dengue, the same fever, but presents with circulatory failure. Third child with the same dengue fever can present in cardiac arrest. But our treatment interventions is going to be very different based on severity. So for the child with dengue and fever who's playing, we may give paracetamol and some fluids, whereas our child presenting in cardiac arrest, our interventions are going to be totally different. So how is the junior daughter going to derive this physiological status? We use a system called the triangle, and we call this the PRAME triangle, where we try to figure out what is happening to the physiological status of the child and then give the intervention. And once the intervention is given, repeat this process till the child becomes better. So the framework revolves around finding gaps in 4 components. It's very simple: A, B, C, and D. That is the airway, breathing, circulation, and the disability. The airway and breathing is what provides oxygen. The airway and the lung give oxygen to the brain. So that is hypoxia. Circulation, if that starts failing, you go into shock or cardiovascular dysfunction. And D, disability, is what happens to the CNS. We develop seizure activity, and how do we control this seizure activity? So it's broken up into its individual components. This is uniform for emergency medicine for adults and children worldwide. So this record has identification data. It also has the targeted history. We don't expect them to have take detailed history on vaccination or their state of nutrition and other or socioeconomic status. This is very focused on the illness at hand. And this is just a few 1 or 2 sentences where they get this information and then circle off these information and then proceed with the assessment. So the assessment of the airway, you can see the breathing, the circulation, and the disability is very, very basic. And they get in these clinical parameters, which again, as they find out, they simply have to circle and score out. Following this, the physiological status is like simple arithmetic. What is happening to the airway? What is happening to the breathing? Is it normal? Is the child having respiratory distress? Is the child not breathing at all? Is the child having a normal heart rate, or is he bradycardic? The heart rate is not adequate, or is he having shock? What is happening to his blood pressure? What is happening to his disability? Is he alert? Is he having altered level of consciousness? Is he having status epilepticus or seizure activity or raised intracranial pressure? So this is the physiological status which is derived from the information, clinical information from the child during when they are seriously ill. And additionally, we send investigations, and these are also documented along with the case record. This also helps us to treat the child. Now, all these variables that I had described earlier, the airway, breathing, circulation, and disability, are fitted around a triangle to derive physiological status, and that aids decision making. So here is a triangle. Here, if the airway is not okay, we do a set of maneuvers. If the breathing is okay, is not okay, then we initiate positive pressure ventilation. Let's say the child is not having effective heart rate, he may be given chest compression and drugs to activate the heart. And if he's having convulsion, he's given anticonvulsant drugs. And then you reassess the impact of your resuscitation within the next minute. So this happens until the child goes into the green triangle where all parameters become normal. And this is the PRAME process. After every intervention, whether it is a nebulizing a drug or whether it's a fluid bolus or whether you have secured the airway or given an anti-fit medication, perform the 1 minute rapid cardiopulmonary cerebral assessment. You immediately document your findings, you interpret the vital signs and derive the physiological status to decide the next step. This is a cyclical process. Even if one sign is of worsening is noted, interrupt. Maybe your child is not tolerating the your intervention, and reconsider what you're going to do. If all variables show improvement, then you can continue till therapeutic goals are achieved. So this is the process which young doctors, junior doctors were taught based on a very simple clinical assessment, which is not dependent on technology. The PRAME triangles are a spectrum. Any combination of clinical variables can be put into these triangles, and we try to derive these arithmetic triangles, and then we treat based on the severity. This is the documentation. As the child is treated, we repeatedly assess. We enter in this pre-formatted case sheets, as I mentioned, till therapeutic goals are achieved or till the child becomes well. So there are many challenges. This assessment needs precision, it needs speed, documentation has to be meticulous, data is based on clinical skills and the motivation of the doctor at hand. The collection is manual, but if it's done, we get remarkable results. And these units, as Sundar mentioned earlier, have been set up in about 28 district hospitals and also 10 medical colleges. And we're giving the training in our simulation, high fidelity simulation lab. We're showing them all this process for nurses and doctors. The government is funding it hugely for to reduce under 5 and child mortality as a whole. The potential impact of this low cost innovation on mortality, we had data from using a PRAME app, which was developed again by the IIT, Professor Venkatesh gave us the PRAME app free of cost. We found that when we use this method, even in the community, we find that mortality is in single digits. And you can see in 2009, all this is pre-COVID data. You can again see it consistently dropping to less than what it was. It has made a huge impact in our Tamil Nadu state mortality, and we hope that this connection that Sundar has given with people working on AI, I hope makes a new beginning, and we are able to help machine learning and AI part of this decision making. Thank you, Sundar, for this opportunity. I really appreciate it. Thank you.
Thank you, Dr. Indu. Very insightful and presentation. A lot of food for thought. And any questions from the audience? We have one question from Professor Arun Tittai now.
Good evening, Dr. Indu.
Good evening.
Yeah. So just a second. I think we have a. Thank you very much. Clean speaker. Okay. Um, yeah. So thank you very much. I think it was wonderful because see, the first talk is essentially imaging, which is my primary research area, and I do understand that it is a high cost entry area, but to really go through your presentation, understand there are so many valuable things that as engineers, as data science, biomedical, we could do a lot of contribution here. So my kind of request is how if we have a bunch of students interested in trying to piece out and see prioritize what could be first, because you listed out several potential topics that I could see. So if they come up, will you some form share, allow me to bring them, have more detailed discussion with you?
Thank you for those comments. I'm currently working exclusively in the skill lab. I don't have access to patients, but we can definitely work on in collaboration. It'll be a great opportunity. Thank you.
Thank you so much.
Ma'am, this is Anirudh speaking. The whole process that you have shown, it was really amazing. I mean, to visualize as well as to think about it. The work you're doing, it's really amazing. How would you see the role of an engineer in creating these kind of processes that require so much of medical insight, which we ourselves don't have by default?
Pardon? I didn't get you.
Oh, ma'am, the process that you have shown to create that one, it requires a person with the medical brain and that kind of experience.
Yes, absolutely.
So,
yes.
So how do you see an engineer involving in this kind of a procedure to,
what we do is, as the assessment is being made, we document this. The documentation is easy. Subsequently, doctors and nurses who are not, unless they're trained, they're not able to figure out what information they're getting from the clinical assessment. And that might be useful if we have assistance in that.
So documentation to conclusion, kind of a mapping is something we can do.
Then, using that information, how do we make the decision?
If I understand right,
the doctor is taking the next correct decision.
Dr. Indu, I think what, if I understand right, what you meant is that the data that is collected by a clinical exam,
yes,
by a trained person, documents a number of parameters, and in order to quickly, the little time that you have, integrate the information from all these measurements and give some action points or a trend or a direction, especially when you follow up from minute to minute with the same cycle, right? Is that what? Yeah. Thank you.
Could I also add a couple of points? Dr. Sanathanam, thank you very much. It's an excellent presentation. This is Anant. I'm really impressed with the work that you have done and you presented. I just wanted to add a couple of points to that question that was just asked. Just from an engineer's point of view, I think for an engineer to start working in collaboration with the clinician, it's very, very essential that you get the opportunity to visit, talk to them, observe them in their native environment, which is the hospital and the clinic. Spend time as if you are invisible, and follow them. That's what I think a lot of trainees, clinical trainees do as well. Keep following the doctor. If you have the time, if you have a couple of weeks, follow them every single day if it's a specific clinician you want to work with, and see what their workflow, what their processes are. And it will really give a lot of insight into what kind of clinical understanding you need as an engineer. The longer the time you spend, the better your understanding is. And also, the more you get a chance to discuss one-on-one, the better your understanding is. So that's just to add to what Dr. Sanathanam already mentioned.
Thanks, Dr. Anand. Thank you. We'll work out. I mean, we'll have further discussions on this.
There's another question. Any insights or ideas or specific problems where one can employ AI into PRAME?
Pardon, can you repeat?
Any specific problems or where one could employ AI into PRAME?
I basically, as I mentioned earlier, it's the most important part of it is making the right decision. It's easy to do the assessment, but the human brain has to put it across and it has to be a very rapid kind of assessment. Usually these are shout assessments because the entire team has to hear what you're doing. It's a loud assessment. If something can capture this and process it and then give us the information on what to do next, that would really be of great help. As they do this assessment, airway stable, breathing, this is what is happening. It's a very loud assessment which the entire team will hear. And if that can be recorded, can be translated into a document, and then the decision making happen, then it will it might help hasten the treatment.
I have a related.
Much of this is muscle memory. It has to be practiced. It has to be done really fast, and often I actually have them timed. So the resident doctor has to do it really fast, and they keep doing it till they get the right findings. So if that is not happening in a let's say a different district hospital where they don't have this volume or the speed, somebody is not monitoring them at the bedside. I am obviously not available to monitor individual doctors in the bedside in, let's say, the Ramnath district or in Perambalur district hospital. Then this kind of process might help the doctors to confidently take decisions. And they supply the data.
That's right. And another area where I think is that even in an urban setting like yours, where every minute you do this assessment and document it, so the output is there, the integrated output of that assessment. So therefore, you could also get a kind of a trend of how each of those variables is progressing, which is shown or visualized in a very obvious way to the group as they work, right?
Yes, the trend is also very important. That's I'm surprised that you're able to pick that up, because that trend goes on for about a couple of hours. If there is a deterioration, if you don't pick up, you can land up in severe. I mean, the child can die. So that trend also can be maybe a machine assisted process.
There's another question. I don't know whether you can see it in the chat box.
I can see it, but I don't know how to respond. If you can share my mail ID, then maybe we could add my phone number.
The question is, ma'am, are you looking for people/startup who can bring AI expertise and work along with you on problems? How can we meet you? So you could be contacted on a mail ID, right?
Yeah. And if any of you all want to meet me, I'm at Children's Hospital at the simulation lab most of the time.
Yeah.
They can actually meet me in person and see what is happening there.
Yeah. So we probably will have a kind of a channel by which members of the audience or others whom they speak to who would like to have an introduction to you and to start engaging with you could contact me, and we will then route accordingly to fix an appointment and visit you, and then take it from there on a individual case-by-case basis. Yeah. Any more questions? If not, I'd like to end the session. It's been a fascinating webinar with two speakers. One technology person who's worked a lot with clinicians, and another is an expert clinician who sees a role for AI. I thank you all for participating, and look forward to seeing you on the next webinar, which is on Friday from 6 p.m. to 7 p.m. We have the first session is from a team in Melbourne, Australia, which will speak on opportunities for AI in elder care or in aging research and care. And the second speaker that day will be from healthcare, from a startup in a company in Bangalore, who will speak on the role opportunities for AI in the area of genomics and pathology. Thank you all very much, and good night.
Yeah, so I'm going to end the meeting for all. Thank you for being here.